All right, moving right along. So we opened with CMS talking about payer to payer, with Steve from ONC giving us a broad view of interoperability. We're going to come perhaps to I guess double click on a little more current events with the patient access rules that everyone's dealing with. We have 3 guests today: Amol Vyas from Cambia Health Solutions, Jeff Strand from Gainwell Technologies, and Jason Teeple from Evernorth Cigna. So thank you guys for joining us. Appreciate it. I'll do a quick introduction just to set the stage of your backgrounds, and then from there, I'd love to hand it over to Amol first, just to share some slides and some materials. We'll then go to Jeff, and then we'll go to Jason, and we'll come back as a group and do some Q&A. Okay. Terrific. So Amol, appreciate you being here. Amol has over 2 decades of experience in enterprise IT with lead roles in strategy, architecture, and implementation, spanning diverse business domains and definitely great depth in healthcare. He represents Cambia and has actively engaged with several payer initiatives and communities to promote the understanding and the adoption of the FHIR standard. So appreciate your expertise and participation, Amol. Jeff Strand is a business solution architect with over 30 years of healthcare industry experience. He's part of the Gainwell Technologies innovations team, where he helps define modular healthcare solutions that align to the CMS Medicaid information technology architecture and evolving state and federal requirements. Jeff focuses on the intersection of federal regulations and healthcare solutions. And I know very well that Jeff's a busy guy. So thanks for giving us some time today, Jeff. And then Jason Teeple, an interoperability evangelist at Evernorth. Jason focuses on the early adoption and strategies for FHIR within the organization. He's also an active participant in numerous work streams in the Karen and Da Vinci communities. So 3 folks who are really steeped, I think, in what's happening with FHIR transformation and patient access at their organizations, and really looking forward to you guys sharing your perspectives on everything you've been doing for the last number of months, maybe longer, and where you sit today. So Amol, I'll turn it over to you.
Thank you, Nolan. Can you hear me fine?
Yes, you sound terrific.
Awesome. Thank you so much, and welcome everyone. It's a tough act to follow, Alex and Steve, but I'll try. Hopefully you can see my screen.
Yes, you're good.
Awesome. So like I said, this is a tough act to follow, Alex and Steve. Alex has been, at the forefront of this revolution, I should say, in terms of coming up with innovative ways to allow patient consumers to get access to their data. And I also want to kind of acknowledge the leadership of CMS and folks over at the CMS implementation team in basically establishing a path that other payers are just following. And I mean the introduction of the CMS Blue Button 2.0 API that basically, with that, CMS threw the gauntlet, if you will, for other payers to follow, adopt the FHIR interoperable standard, and enable their member consumers to get access to the data through third-party apps of their choice. So very much excited, and with 1 week remaining for the enforcement deadline, I think this is a revolution just waiting to happen, where third-party apps will hopefully enable consumers to get more of their data and really get a 360-degree view of their healthcare journey. And to what Steve said earlier, the clinical data revolution has already happened with the Argonaut and upcoming US core API implementations. The payer side is just coming online here. And I'm really excited that we're meeting the clinical domain in enabling and unlocking the access and the data for consumers. A little bit of an overview, if you will, on what these rules are that we're talking about here. You've probably seen this slide before, and the specific part of the rule that I'm talking about here is the Patient Access API, which had a deadline of 1/1/21 of this year, January 1st of this year, but has an enforcement deadline of 7/1. On the left-hand side, I've got some implementation guides that payers could use, payers subject to the rule could use to basically be compliant with this Patient Access API. The first one is the Karen IG for Blue button, also known as Consumer Payer Data Exchange, Consumer Directed Payer Data Exchange. The claims and encounters are covered as part of this IG. So any adjudicated claims that reside within a payer's system of record, they can be exposed through this implementation guide through various third-party apps that the member can choose. The other aspect of the Patient Access API is the clinical data described by the US CDI version 1, United States Core Data for Interoperability. And that domain is covered by the PDEX implementation guide, which is really a layer over the US Core implementation guide. And so with the clinical part covered, the remaining part is the drug and formulary, plan coverage and formularies as far as the plan APIs. And that's covered by the Da Vinci drug formulary IG implementation guide. And so we have pretty much the entire blueprint for how plans can realize their compliance with Patient Access API. Again, all these IGs use the latest version of FHIR, which is R4, and kind of push the needle on achieving that interoperability, nirvana, as more and more entities adopt the FHIR standard, data exchange becomes easier. And so these are the IGs that are the center of this 7/1 date. The next page kind of talks about what some of the common challenges are, and this is data that we've collected as part of the Connectathon tracks that we've organized with respect to Karen and possibly other implementation guides as well that I've participated in. The main data point that we've observed is that the consumer or consumer app-facing APIs is a totally new thing for most of the payers out there. Payers are simply not familiar with this particular area of information technology. That has been our observation. I mean, some payers are obviously out there. They already have existing consumer and consumer app-facing APIs, but majority of the payers, this is new to them. And hopefully this rule and then the implementation aspect kind of pushes them to introducing APIs in support of the Patient Access API rule and other APIs beyond the rule as well. But this was definitely something that the payers are learning to kind of get better at. The second challenge is interoperability standards. Payers typically are interested in doing integrations that are tailored or custom based on the specific integration scenario. And so, and again, I don't speak for all the payers, but most of the payers I've seen are, end up inadvertently creating one-off flows or silos. And so reusable, common, and open interoperability standards like FHIR are definitely new to those payers. And so this rule again introduces this standard, wonderful standard called FHIR to the payers, and kind of again pushes the envelope in terms of spreading fire, sorry for the pun, within the payer community. So we're very excited about that as well. Some of the other challenges in terms of tactical implementation aspects are distributed systems of record. Several payers delegate their benefit management functions like pharmacy, vision, oral, resulting in distributed systems of record. And so bringing all this data that resides in the claims system of record, if you will, or clinical, to expose a common patient access API becomes a tricky situation. And so that's a thing that payers are kind of grappling with and trying to figure out certain best practice approaches, whether it's a proxy thing that they want to go for, or a pipeline, a data pipeline. But this is one of the challenging areas for payers. Then there's the area where you're dealing with scenarios where there's other local, state, and or federal rules in play. An example is keeping track of guardians in the case of child-only accounts. According to the FTC COPPA, a minor is not able to basically exercise individual right of access. The parent or the guardian needs to do that on behalf of the minor. And so these tricky scenarios where, hey, we've got to keep track of the guardian for the child-only accounts, and we might not be doing that by default under our enrollment flows. And so this is basically resulted in payers looking at their other workflows, related workflows, to make sure that they are in compliance with not just the patient access API, but other local, state, and federal rules. So those are some of the high-level payer challenges. Again, nothing that cannot be overcome. These are all part of the growing pains, I should say, as payers become more consumer centric, consumer focused, and help the consumers make informed decisions about their healthcare journey. Last but not the least, I want to quickly point some references. Again, I'm not going to go over all the references here. The final rule guidance page link provides the same information, or most of this information, in detail. I do want to do a quick plug-in for the upcoming CMS Virtual Connect-a-thon organized by HL7, where all the implementation guides that you've heard about that are for 7.1, as well as the peer-to-peer data exchange requirement for 1.1, they're going to be offering tracks at this event. So I welcome folks to kind of join us in making this event a very important journey towards compliance. That's all I had.
Terrific. Thanks, Amol. There's definitely some questions, but we're going to go to the other two, to Jeff and Jason, and then we'll circle back as a panel afterwards. So if you want to stop sharing, Jeff, you can bring up your materials. Great, we can see them.
Great. Is it in full view, full mode?
It is, yes.
Okay, great. Okay, so we've been talking all day about the patient access interoperability, so we know what the goal is. And so I'm Jeff Strand, and I'm with Gainwell Technologies, and we play a leading role in the majority of the state Medicaid programs in the nation. And so for us in particular, the challenge here was we have a time-boxed imperative to translate this data and access this Medicaid data in an entirely new way. So as Amol just alluded to, FHIR is a completely new language to almost all of the Medicaid accounts. And we currently have 2020 implementation in some level between contract negotiations and in production with published mandates. And due to the timing of that federal mandate, we're stretching our resources quite a bit. So what are some of the critical success factors in this process? And first and foremost is we have a great teaming partner. Gainwell Technologies specializes in Medicaid. One Health specializes in FHIR, and it's the union of that knowledge that was really useful in this program, especially as it came to the data mapping and the translating of that administrative data, which is the first time that FHIR's really taken on administrative data, and creating that outcome is the union of knowledge between FHIR and deep Medicaid knowledge that really helped there. Another critical success factor is reproducible architecture. So this is a platform as a service, which is serverless clouds leveraging a lot of the cloud native capabilities. We use a templated deployment for a standardized setup. And in some cases, the FHIR environment can be initiated before the account can even open a firewall portal to share the data. Security is wrapped through the fabric of the entire platform, and it's SOC 2 and Type 2 verified. One of the greatest success factors for us in particular was data standardization. So CMS requires all of the Medicaids in the nation to share with them on a monthly basis a set of 8 data files that are really the breadth and width of the information from a Medicaid, and CMS uses that to make data-driven policy decisions as well as to produce some standard reports. And so we leveraged that concept, augmented it with some state-only people. So we used the format of that all the Medicaids were used to as producing this very rich set of data that we would be able to then populate those APIs with. Because of that, once we had done the initial mapping of TMSIS into FHIR, we are able to take an account from initial kickoff, from project kickoff to populated FHIR endpoints in somewhere between 90 and 120 days if it's a straight implementation. Now, most Medicaid systems don't have clinical data, and as such, if they did, and we have some that do, then there's more time necessary for the mapping, translation, ingestion of those particular pieces. Now, we did have a couple of accounts which, for this reason or that reason, couldn't use the TMSIS data. And for them, we had to do a custom extract of the data. We had to do custom mappings. We had to do custom translations. And those took significantly more time because we couldn't leverage that pre-mapping information. And if we would have had to do a custom extract and a custom mapping for each of the Medicaid programs, we would never have had enough resources to begin to meet the time allocated for that. So the data standardization was just huge for us to be able to produce at scale. Another critical success factor is an agile approach. We've talked a couple of times already that everybody is starting with the Karen consumer payer data set. And so this is the core set of data that is required at the base of the record. And so we started there, but then we iteratively layered on more and more of that optional but very valuable data that's available in the TMSIS extracts that is allowable within the FHIR resources. And we could then share those extended maps both with our existing clients and with the new clients as they were coming on board. And so that iterative expansion really helped in the expanding the amount of time it allowed us to complete the complete data. Now, this really showed the value of CMS's goal of leverage and reuse. Again, without the leveraging of the standardized data, we would never have been able to meet our times. But that said, there are challenges. And chief among them for us is privacy. Medicaid for 40 years has prided itself in how good it protects data. Security and privacy are etched into the very DNA of the policies and of the security processes for the whole process. I've been in the industry for 35 years, and every year I take a HIPAA security and privacy set of required training. And as a matter of fact, very few people in the industry actually know that the P in HIPAA is portability and not privacy. So publishing PHI data to be accessed by third-party apps is just a cultural anathema that's really hard to overcome. So we followed CMS's Medicare blue button method of when we're registering a person to their longitudinal record, we have them supply data that they will know and that we will be able to verify in the data so that they can self-register for that. And it'll tie to one and only one person. So we do allow for that self-registration authentication. But as was noted, in Medicaid, more frequently than in other health insurance, sometimes child custody plays a role in that. And whether it's in adoption support or whether it is in foster children or child protective services, sometimes the custody of the child will change. And we're currently working with our clients to find a way to have changes in the data itself trigger a revocation of the association between that particular third-party app and that particular record, and then require them to re-authenticate to ensure that they're still having a continuity of care and the right people are accessing it. That's a work in process, right? It's not something that is fully complete yet, but we're working on it. One of the things that may play a role is digital credentials. Companies like ID.me or the Government Service Administration's login.gov are able to generate and create some digital credentials which could play a role in the authentication and logging in of people over time. That said, we did have the vaccine passport discussion recently, and while technically it is possible, there's still some cultural resistance to the digital credentialing of people, so that may play a stronger role and it may not. As has been said here many times, this is a fast evolving specification, and that means that there's going to be constant change in the payer system. In 2019, FHIR 3.0 was prominent. Now it's FHIR 4.0. FHIR 5.0 is already under discussion and under balloting. The Karen Blue Button implementation guide is in its first iteration, and as the payers and as the third-party apps and as the patients interact with it, it'll change. Already there are changes coming that they intend to ballot, but especially over this next year as we actually have that use of it, I'm expecting there will be quite a bit of change there. As has been previously mentioned, there are numerous FHIR accelerator groups, Da Vinci, Argonauts, Karen, the Gravity Group, and they're all expanding the scope and width of the solution so that we'll have new different uses for this data, which again is going to require us to think carefully about that data security and that data use management and privacy and consent and whatnot. So there's a lot still that we are not fully mature in, and we will evolve in that over the next couple of years. But again, as I said, Medicaid's been doing privacy for 40 years. This is going to be new to a lot of us in terms of how do we still protect that PHI. And as has been mentioned, there are new federal regulations coming that are going to extend this, possibly not even to the patient access realm, but to electronic clinical quality measures to HEDIS measures to other kinds of star rating value-based pricing are going to be other uses of the FHIR standard, which are going to require systems changes from our part. So what's the impact? Full truth in advertising, we're uncertain what percentage of the Medicaid population will actually make use of this patient access opportunity. My own personal opinion is that the most likely use will be on that new patient intake. When the patient goes to the doctor and he says, what are the medications you are on and what was the date of your last mammogram? If you could use your phone as opposed to your memory to answer those kinds of questions, I think the healthcare outcomes would be better. I think that there are going to be, over time, health management opportunities when we combine the Medicare patient data with perhaps wearable information and schedulers and other ways of creating a healthcare management ecosystem. I think that'll be where the highest value will be. One of our current problems is in the data fragmentation, where in Medicaid in particular, members will move from, say, employment-based healthcare to Medicaid and then back again. And even within Medicaid, they may have MC or managed care data, which may be held differently than in your fee-for-service data. So we still have some data fragmentation to work with. We're in the early steps of our journey, but I think it's going to be a journey that will be good for us all. And with that, I'd like to turn it over to Jason.
Thank you very much, Jeff. Hopefully everyone can hear me. All right, excellent. Yeah, so I'm coming from Evernorth, a little bit different perspective from Amol and from Jeff. And the reason why I'm saying that is because we're coming from a perspective of we have a growth by acquisition model for many years. And when you take along that perspective, what happens is you kind of have data across many different parts of your organization. And when you have a regulation that's asking you to bring in qualified health plans, bring in Medicare, Medicaid, you start having your data distributed. But before we even get to that point, one of the things that we had to really do is take a step back and educate. That was the biggest piece of our process, at least early on, was just educating our business partners and then educating our technology partners. And when you go into that level of detail, it takes some time because you're talking about a regulation which has a finite way of being explained. And then you have the perspective of your legal department, which may be a little different than what you may hear from other legal departments. And then you have everyone else's perspective on that regulation. Someone who may have read it once or skimmed through it, they'll have their perspective. So it's a lot of, first, let's educate you on what we're trying to accomplish from a regulatory standpoint. Second, let's correct any maybe misnomers that may be out there based on misinterpretations or other kind of run-of-the-mill conversations. And then let's make sure that once we have a good foundation of what we were trying to accomplish, we have to educate you yet again on what's happening with FHIR. And that's one of the pieces that probably took us the longest time, is that we had some teams that were coming into this that didn't necessarily understand what it meant to have FHIR, and that wasn't necessarily a data standard, is a framework. It's a framework because you have your platform, you have your FHIR server, but how are you going to get that FHIR server up and running is one perspective. And then you need to take in the concept of the data. You need to get your data from its native format and whatever repository it lands in or wherever it comes in, and you need to bring it over into a FHIR format. So we had to take the time to educate our technical teams and say, okay, here's what we need you to accomplish for a FHIR server. Here's what we're looking for in terms of functionality. Here's what we need in terms of compliance. And here's what we need from a security standpoint. And once we got that team under control of what we needed to accomplish, the next part was, okay, let's talk to our business teams. Let's talk to our SMEs that understand where this data resides and help them understand what we're trying to accomplish in terms of implementation guides. And that was an interesting topic because a lot of the teams aren't used to coming from the perspective of, hey, here's a document that tells you exactly what we need to accomplish, and here's how you're supposed to accomplish it, and here's what's required versus what's optional versus what's, you have some flexibility in terms of what you need to present. That created some confusion. It also helped create some clarity as well, because when a question came up, well, is this required? We'll just look at the specification, and it will tell you exactly what we need to do. When there's optionality, we need to kind of educate our teams and say, hey, listen, just because it's not required doesn't mean that we shouldn't provide the data. If we have it, we should provide it, especially if it brings value to the data that we're trying to present. So once we kind of get those teams on board, the next part was bringing our security and information people kind of up to speed. As everyone kind of mentioned so far, we are going down a journey of making this data available through APIs. We're not building the user interface. We're not in control of what the user interface looks like. We're also not in control of what we can necessarily expose, right? The regulations tell us what data we have to expose. The regulations tell us how we have to expose the data. And it also, we have some guidance on what we can and cannot do in terms of shutting down access to the data and getting our security folks on board with the concept of we have to make the data available to a third-party app. We have limitations on what we can and cannot reject. So if an unknown third-party app comes to our table and says, hey, we want access to your data, we can't necessarily turn them down because they don't have brand recognition. We can look at them and say, okay, well, tell us what you're trying to accomplish with this. Let's go through some minor security controls. But at the end of the day, we have to give access to these third-party apps unless they're doing something completely malicious that we can prove, or they're abusing an endpoint. So there's really limitations on what we can handle here. So once we got our security folks kind of up to speed and in agreement and understanding what we're trying to accomplish, we had to go back to our business partners yet again and explain to them, we still can't control what the data looks like when it gets out there. We make the data available. We essentially build the pipes. We flood the pipes with some water. And then how that water looks when the third-party app consumes it, that's out of our control. And that was really an interesting conversation, because the business team really wanted to control what the conditions may look like, or what immunizations look like, or how we present a membership card, a member information. And getting them to understand that that's really not our design considerations. We just make the data available. They kind of had to take a step back and say, okay, well, let's make sure then that we are being educational to the third-party developers and making sure they understand what data we're bringing back and what data we can share forward, so that the member has the institutional knowledge of what they're trying to view and what the third-party apps need in order to make the information kind of recognizable. And once we get to all of that, we go back to data mapping yet again, because we have these implementation guides, and we have to now take all that information, take all that knowledge that we just built in terms of what we're trying to accomplish and how we're trying to accomplish it, and get our data mapping teams to source all this information. And sourcing it is just when you, as I mentioned earlier, growth by acquisition, when you're trying to source all that information, you're now cutting across lines. And when you start cutting across lines, you run into proprietary code sets or proprietary value sets. So there's a lot of translation that happens there. So when you see that the specification says it's an extensible value set, well, that's great, but we have the data, proprietary data set. So that's additional work that the teams have to take on. So there's a lot of kind of back and forth on what can and can't we do? How do we have to present this information? Do we have to do a crosswalk? Do we not have to do a crosswalk? So within the first 6 months of educating, getting teams up to speed, there's a lot of going back and kind of re-educating, saying, okay, well, we can't provide condition information this way because you use all proprietary code sets. It's not going to make any sense to the vendors as they go out there, and it's easily crosswalkable. Why don't we just go back and look at the data and just do a crosswalk to make it kind of uniform in terms of what we're trying to present? The next piece is, once we get the mappers up and going, it's understanding what does the data look like, right? It's testing. Once we have the data in FHIR, we get into a FHIR server. It's going back and saying, okay, how does this look to the member? How will this look to the consuming app? And that really is kind of the long pole, is understanding what we're trying to accomplish. When we first did a demo to our business teams, they were shocked on how our data looked, because we only did a certain set of data. We only did a couple of resources, and we try to explain to them, here's what our mapping looks like. Here's what we think we're seeing. And the business team is like, well, this doesn't make sense. So we had to go back and kind of re-educate and say, okay, well, here's what the specification needs. And there's a compromise with the mapping team saying, okay, well, yes, certain elements are only required and some are optional, but we're hearing now from our SMEs and from our business teams what's missing and why this information doesn't look like it's in proper context. So that's been a lot of what we're trying to accomplish, at least on the Evernorth side, is just combining all these different lines of businesses that we have in different spaces that we had through acquisition, bringing all the information together to make it a seamless experience for the member. And to kind of go backwards, what we did from an architecture perspective is we had to give a whole new perspective to both our business and technical teams. We had to take a view of what does this look like to the member, and showing an app and then showing a member and showing multiple apps. That was new to our technical teams because they're not used to seeing that maybe an external user can come in through a variety of channels and request their information. So we had to show that walkthrough of what does it look like from a new perspective of, we have a new party, right? It's the developers. The developers are essentially acting as our proxy to the members now. So we have a person sitting in the middle of our exchange with the members. So how does that experience look like from a developer? So we had to go from an architecture perspective and walk through our teams what it looks like for a developer, the importance of a developer portal, the importance of the education information, the material, the sandbox, all the information that's available on our developer portal, and give the insight of why we want to do a developer portal and why it will help us in the long run and why it will help developers in the long run. Once we got through that perspective, we go, okay, great. Now we have them up in the sandbox. Now let's show what it looks like for a member. What does it look like for a member? They first have to go find that app. Once they find that app, they have to say, they want to give access to that. So what does that look like? And so showing the perspective of a member going into a third-party app and then getting redirected to the MyCigna login page to give authentication to authenticate and then authorize access to the information. That was a new perspective for both our technical team and really our security team as well, because they didn't understand that we're redirecting and then going back and creating these JA tokens and explaining how the FHIR launch sequence essentially works. So once we got to show all that, we basically show, hey, now you're hitting our FHIR server. Now you can access it within the context of that member that authenticated and authorized and the information that's going to flow. So just to kind of summarize it all up, from an architecture perspective, what we did was we had to educate, we had to inform, we had to go back and re-educate. We had to sit with these teams, sit with our teams and kind of help each team that had a delivery component, help them understand where we're trying to make FHIR available to all these endpoints. And it was just a great opportunity to kind of bring these folks all together, educate, and make it available for, at the end of the day, the patients. So I'll pause there and hand it back over to Nolan.
No, that's great, Jason. Thank you. It's interesting. You guys all had those same themes roll through, your talks of the learnings of, educating the teams of really the hurdle of privacy and security, right? Getting them comfortable with this new world order, putting the portability P back in HIPAA, Jeff, and then that notion of the developer between you and the member, that sort of new paradigm of relationship, Jason, pretty interesting. Are there any lessons that you guys have learned over the last number of months that you can use in the upcoming payer-to-payer implementation? And maybe, Jason, because you're already warmed up, we'll go back to you first.
Yeah, absolutely. I think the importance of having a standard that you can work towards. I understand that payer-to-payer right now is basically saying, get your data out the door through electronic means, but having a standard in which everyone can work towards is going to be the most important piece, and having a repeatable pattern, right? The more that we can reuse what we already have in place in terms from a data perspective and an access perspective, it's great, but we have to understand where our audiences are, right? Now I'm going to be connecting with Amol. Amol wasn't connected with me before. Now we're trying to connect. So we need to make sure that we're sending data the same way and that we can access in a similar pattern, because that's going to be something that we see as important. One of the things I see under the covers that people may not talk about is that when payer-to-payer comes up and Amol sends me FHIR, well, how did he validate his FHIR? Did he use HL7? Did he use the IBM? Did he roll his own validator? What happened, right? Because when that data comes in the door, it may not pass through, and we have to have checks in place for that. So that's going to be something I think we're going to have to learn. Predicting that maybe a future kind of impact, maybe it's jumping ahead here, but I think that's something that we're going to have to take as a lesson learned. What we're trying to do today to get for patient access, we're going to have to consider for payer-to-payer.
Yeah, A lot of head nodding from Amol. Amol, do you agree with that?
No, I totally agree. I think there's the two major questions out there in terms of peer-to-peer. Number one, it's barely 6 months away in terms of enforcement. And number two, how can we leverage what we're already building, as payers? How can we leverage what we're already building for the patient access API? And I think that's where most of the conversations are kind of, going on. And hopefully we will have some consensus given some of the, I wouldn't call it gaps, but given some of the, I guess high-level guidance in the peer-to-peer data exchange rule. How can we get the payer consensus to decide a common, for example, format, let's say FHIR, a common mechanism for transport, let's say, smart app launch, and those kinds of things. So I'm hoping that there will be some consensus. There's some awesome conversation going on within the Da Vinci circles that I would invite folks to attend if you're not already doing that, where we're talking about a couple of models where this is all gonna make sense.
Yeah, definitely. In a couple speakers, we'll get into more of the Da Vinci models and show people how they can get invited. And there's some, we'll talk you through that. What would you think, Jeff, I guess for you, like what's been the biggest replicable learning as you guys think about the future?
Well, I think that once we begin to actually use the data, we're going to learn a lot of lessons, right?
Yeah.
We are building to a paper specification that's a trial use implementation guide. The third-party apps are building to a paper specification. It's when that data actually gets together over the next 3 to 6 months that we're going to actually both grow in terms of the data needs and the error checking that's going to be necessary, as well as the use and presentation of that. So I think that the initial people will honestly probably be a little bit disappointed, and they're going to kind of say, is that all there is? And it won't be, but we're going to need some time to actually move the data through the pipes to see it on the screens and whatnot, to build that richness in that the patients will want. So I'm hoping they'll give us a little bit of time to build and mature, because right now we're building to a paper specification. We haven't literally pushed the data through the pipe.
Yeah, great reminder. We're at the beginning of an iterative process for sure. Lots of learnings and lots of collaboration. So thank you guys, Amol, Jeff, and Jason for joining us today, for sharing your experiences. Really appreciate it. And best of luck as we look towards the future here.
Thanks for having us. Thank you.
All right. Take care, guys. Thank you.